Thank you for joining us for this evening's monthly provider seminar. My name is Paige Bellenbaum, and I am the founding director at the Motherhood Center. And this evening, we are going to be hearing from Dr. Robakis, and the issue of the evening is breastfeeding and medication use, guidelines and considerations for treating PMADs. For those of you that are joining us and hearing about the Motherhood Center for the first time, I just wanted to take a few minutes this evening to tell you a little bit about who we are and what we do. We are approaching our 4th birthday here at the Motherhood Center, located in New York City. When we're in bricks and mortar, located virtually like so many of you are in your practices over the past year. What we do at the Motherhood Center is we specialize in treating new and expecting mothers that are experiencing what we call perinatal mood and anxiety disorders. The acronym for that is PMADs, and PMADs really acts as an umbrella with a number of different diagnoses that sit underneath. So depression, anxiety, PTSD, OCD, psychosis, all during pregnancy and postpartum. So these symptoms and diagnoses appear in the perinatal period. We offer support groups to new and expecting moms. We offer outpatient treatment via perinatal therapists and reproductive psychiatrists. And what we do that's very special, that really only exists in a handful of other places nationwide, is our partial hospitalization program, what we call our day program. And this is an intensive level of care for pregnant and new mothers that are having a really difficult time caring for themselves and or their baby. So the day program is that intermediate level of care between outpatient treatment and inpatient, and meets 5 days a week for 3 to 5 hours a day, and really helps new and expecting moms feel much better and recover from their PMADs much faster. We also like to offer a lot of education, like this evening's event. We do monthly provider seminars like this once a month. We also host a number of webinars on an array of different topics that has to do with the perinatal period and new and expecting mothers. And just wanted to let everybody know that our next monthly provider seminar is actually coming up towards the end of this month. It's called Reproductive Identity, What It Is and Why It's Important. That's March 18th at 6:30 with Dr. Aurelie Athan from Columbia Teachers College. Now, I'm going to kick it off and briefly introduce Dr. Robakis to you. And I'm just going to ask that if anybody has any questions that come out throughout the presentation this evening, please feel free to put them in the chat. And we'll try to leave the last few minutes of the presentation this evening so that Dr. Robakis can get to some of the questions. So without further ado, Dr. Thalia Robakis is a psychiatrist at the Motherhood Center who sees patients in our outpatient program. She completed her MD as well as her Ph.D. in developmental neurobiology at Columbia University's Medical Scientist Training Program, residency training in psychiatry at Stanford University School of Medicine, and a research fellowship in perinatal mood and anxiety disorders also at Stanford. She's an expert in the management of psychiatric disorders in pregnancy and the postpartum period. She takes a holistic approach to patient care, including providing or recommending behavioral, psychosocial, psychotherapeutic, pharmacological, and neurostimulator interventions as necessary and appropriate for each mother-infant dyad. She wants all new moms to remember that the best gift they can give their babies is a calm, happy, and well-rested mother. So I'm going to turn it over to you, Dr. Robakis, and you can tell us all about breastfeeding during pregnancy and postpartum.
Great, thank you so much for that kind introduction. So today I was going to give an overview of physiology of lactation, basic principles of medication and breastfeeding, and then also I'm going to go into specifics of certain medications, either that we use frequently and some recreational substances that also have psychotropic effects. For some reason, my slides won't advance. So basic physiology of lactation. So breast milk is made in the alveoli. These are little lobules of cells. They draw products out of your bloodstream and manufacture the milk. The milk then travels through these milk ducts to these storage sinuses, and it accumulates there. And then when the baby feeds, the sinuses are triggered to release the built-up milk. Lactation is under very complex hormonal control. So breast tissue actually does not mature completely until a woman has become pregnant and delivered a baby. If you've never had a baby, then your breast tissue is in like a premature state, and it enters lactogenesis 1 at about mid-pregnancy. Once you deliver, then your breast tissue enters into lactogenesis 2, and that's triggered by the drop in progesterone. So while you're pregnant, your placenta is constantly secreting progesterone, which helps to maintain the pregnancy. And then as soon as you deliver and deliver the placenta, then you lose all of that progesterone, and that signal is what triggers your body to start making milk. If anything goes wrong with that process, like if the placenta doesn't come out completely, if there are little pieces left, and that can interfere with the signal to start making milk. Then there's this period of time where your body enters lactogenesis 3 and is gathering information about about your baby's milk needs for the long term. So for the first maybe 4 to 6 weeks after delivery, there's this critical period where milk is just being made, usually lots of milk at the beginning, and then your body's kind of keeping track of how much milk is removed. And the more milk that's removed, and the more frequently it's removed in this critical period, your body will lay down more prolactin receptors in the breast tissue, and that will enable you to build like a larger supply for the long term. Once you leave this critical period at about 4 to 6 weeks, then supply for that period of lactation is much more fixed, and it's harder to move it outside of certain parameters. During ongoing lactation, breastfeeding is mostly controlled by these two hormones, prolactin and oxytocin. So prolactin triggers your body to make the milk, and then oxytocin triggers your body to let it out for the baby to feed. And so how can drugs get from the blood into the breast milk? So there's several routes, and it actually depends on the characteristics of the medication in question. So small substances and water-soluble substances can move directly through like aqueous pores. Products that are like medications that are lipid soluble that will dissolve in fat can diffuse across the plasma membrane. And then many drugs actually have active transport, where there's a specific protein transporter that will pick them up and move them across the cell boundary and into the milk. And that's done selectively. It's really important to know that anything that's in your blood is going to exist in some kind of equilibrium with the milk. So again, so the ACE&R cells, remember, they're drawing all the products to make the milk from your bloodstream. And things that are in your bloodstream are going to be moved across this barrier into the milk, but they're also going to go back. I mean, like almost any chemical reaction, they proceed to some kind of equilibrium, which could be far to the left or far to the right. But, you know, once it reaches that equilibrium, there becomes kind of an equal transfer of the drug or molecule in question, both back and forth between the milk and the blood. So the drug will enter the mom's bloodstream after she ingests it. Drug in the blood can either be free, like floating around by itself, or a lot of it is often protein bound, and if it's protein bound, it's much harder to move into the milk. On the other side, drugs that are lipid soluble will be much friendlier to milk and will tend to stay there. So this equilibrium will be far to this side. Drugs that are protein bound will have the equilibrium far to this side, but in general, you're going to be seeing constant transfer of drugs back and forth across across the membrane of the acinar cell. So that equilibration of drug between blood and milk is why it's really pointless to pump and dump. So don't listen to anyone who ever tells you to pump and dump. Why? Because. So this is a diagram of an example drug that's in the mom's blood and also in her milk. And because the mother's blood is a much larger reservoir than the milk that's only in the breast, then there's always going to be more drug distributed in her blood that runs throughout her body than the amount that's going to be held in the milk that's in the breast. And again, there's going to be like an equilibrium between those two, so that some drug is going into the milk and some drug is coming back out of the milk. And depending on how protein bound the drug is and how lipophilic it is, that equilibrium will differ. When you pump, okay, so you pull out, say you pump once and you drain the breast and you pull out like all the milk with drug that was in that breast at that time. You're very quickly then gonna, so whatever was now still in the blood is just gonna re-equilibrate with the breast. And now you've removed, okay, so from the entire reservoir of drug in the body, you've removed that little bit, but you're basically just gonna have re-equilibrium pretty soon, and you're gonna have almost the same amount of drug total, and it's just gonna re-equilibrate between the blood and the milk. So it's really like not at all useful to pump milk out and then dump it, because the drug in the milk is not static. It's continually re-equilibrating with the drug in the blood. And so what you really need to do in order not to have drug in the milk anymore is wait until mom's liver or her kidneys clear the drug out from her system. If you want to avoid exposing the baby to a drug that's been taken, the better thing to do is, generate some clean milk for the baby to drink, which you can pump ahead of time, or you can give the baby formula or whatever. And then you wait until your liver has eliminated the drug from your bloodstream, and then feed the baby. So there's a number of factors that can affect whether, like, how safe a drug is to use in a breastfeeding mother. One of the most important factors is the inherent toxicity of the drug. So some drugs are potentially pretty toxic, like, or they have a low toxic therapeutic window. Like, for example, lithium, it's quite easy to do quite a lot of damage to yourself with a lithium dose that's maybe only like 2 or 3 times as much of what a dose would be to use for like a therapeutic purpose. Most of the commonly used antidepressants have pretty low toxicity. Like, it's really quite hard to do much damage to yourself with an overdose of Prozac, for example, and you'd have to take like really quite a lot of Prozac to cause any kind of problem. So the inherent toxicity of the drug is a really important factor. Maternal factors, so everyone's body is different. One woman may take a given dose of a given drug, and another woman may take the same dose of that same drug, and they may end up with really vastly different blood levels, just because like one person's liver works faster than another. And so there are a lot of differences in the ways that our bodies handle drugs, and therefore sometimes we use very different doses in different people. Factors about the drug are important. Like, for example, if it's highly protein bound in the blood, it won't easily go into the milk. If it's highly lipid soluble, it likes to be dissolved in fatty substances, then it'll tend to go in the milk and stay there. And again, some drugs have specific transporters that carry them into the milk. The infant factors are also really important. So just like moms, infants have very variable rates of drug elimination. And probably even more variable because a lot of this has to do with the age of the infant. So newborn babies, their livers are not very mature. They don't eliminate drugs the way an adult liver does. And this is even more so for premature babies. The size of the infant is really important. So the amount of drug that they get in a given amount of milk is going to be diluted over their whole blood volume. And the bigger the baby, then obviously the more they can tolerate. The amount of milk they're taking in is important. The timing of feed, whether they're timing during that window when there's a lot of drug in the system, or if they're feeding like, farther out when the drug has had a chance to be eliminated. And then there are certain things that would make the baby more vulnerable. Like if the baby's premature, then their liver is even less mature and even less able to handle medications. If they're dehydrated, that's often also like a really big risk factor. So it's a really different situation to take a medication and breastfeed like a healthy 6-month-old who's been breastfeeding for a long time. It is like nice and fat, versus like taking the same amount of drug and then breastfeeding like a very small premature baby who doesn't have the ability to eliminate that the 6-month-old does. So that concludes kind of the general overview section, and now I'm going to go into a discussion of specific psychotropic medications, and these are the ones that we use, probably most commonly. And I'm also going to talk a little bit about recreational substances at the end as well. So antidepressants, so there's a lot of variability in drugs that are called antidepressants. There's a number of classes. Most of the ones that we use most frequently now have pretty low toxicity, which is one of the reasons why they're much more in favor than some of the older drugs that are just as effective or even more effective, but maybe have more toxicity than the common ones. So SSRIs, so selective serotonin reuptake inhibitors, are the most commonly used antidepressants in pregnant and breastfeeding women. Transfer is usually pretty low for most of these. It's higher for fluoxetine, which can get up to about 10% of the weight-adjusted maternal dose, which is kind of getting into the moderate range. But most of the other ones are certainly under 2% and often, under 1% or in the undetectable range. And SSRIs generally have pretty low toxicity. So again, even if you overdose on an SSRI, you're not likely to do like major organ damage. So that's another reason why we often feel quite comfortable with breastfeeding moms. So neither the transfer is high nor the toxicity is high. So the SNRIs, which are duloxetine, this is Cymbalta, venlafaxine, which is Effexor, and desvenlafaxine, which is Pristiq. Those are a little more variable. Duloxetine also has very low transfer. Effexor and Pristiq have a little bit higher transfer than duloxetine. So, I mean, if you have a choice, I tend to stay away from those, and honestly for pregnancy as well for other reasons. Tricyclic antidepressants, so these are kind of the older ones that I mentioned. They're not nearly as commonly used now for depression. Actually, they're much more commonly used for pain indications like migraine or sometimes different kinds of gastrointestinal pain. They have a much lower toxic therapeutic window than SSRIs and SNRIs, but they really don't penetrate into the breast milk hardly at all, like very, very limited. So we mostly are not, super concerned about using these in breastfeeding either, just because the transfer is so low. Bupropion, which is a Wellbutrin, it's kind of in a class by itself. This has more of like a moderate rate of transfer. In general, this is safe for most moms and babies. It is well known that this drug lowers the seizure threshold, which isn't a consideration in people who aren't otherwise predisposed to seizures, but I mean, we don't give it to people who have other reasons to have a seizure. And there have been a couple of case reports, usually when mom was taking this in combination with something else, which might have increased the amount of drug in her system, where there were babies who had a seizure. In general, like I said, if you have a healthy full-term baby and mom is only taking one medication and there's no other reason to be concerned, then this is safe to take. And I mean, I've never had anybody tell me their baby seized on this. It's a pretty rare outcome. And then mirtazapine, which is Remeron. This is also one that we use a lot. It's great for sleep. It's very calming. And that also has a relatively low transfer and low toxicity. So also one that we're not supremely concerned about in breastfeeding. So most of the commonly used antidepressants are reasonably safe for breastfeeding. So benzodiazepines, these are anti-anxiety medications like Valium, Klonopin, Ativan, and Xanax. The toxicity is kind of more moderate in this group, and the transfer is also more moderate. It's pretty variable. It can be between 3 and 8% of the weight adjusted maternal. They are like sleeping pills or sedatives. So if there's going to be an adverse effect, it's usually related to sedation of the babies. So the babies can get somnolent, they can have poor muscle tone, they might not be awake enough to feed. In general, we like to stay away from these. If they're necessary, for, short term, usually the shorter acting ones are safer than the longer acting ones. And this is a little different from what is usually done in like non-breastfeeding individuals, because a lot of practitioners feel for clinical reasons that the kind of sustained drug level is better than like a rapid up and down. But for a breastfeeding mom, actually you don't want a drug that's hard to eliminate, because you don't want it to build up in the baby's system. Like when there have been cases of infants who were sedated, usually it's because mom was taking a long-acting drug, and so baby can't even get rid of what they had last time before they get another dose, and eventually it starts to build up and overwhelm their ability to eliminate it. So if we're going to go for these, we're usually going to go for lorazepam or an alprazolam rather than like a diazepam or clonazepam, because the baby will be able to eliminate it and not have it build up and cause sedation. I think one point that I really want to emphasize, which is going to come up again, is that more concerning, honestly, to me than transfer of drug to the baby is what the drug does to the mom. So again, like any kind of sedative or sleeping pill is potentially a cause for concern when you have somebody who needs to be responsible for a baby overnight. If the person who's normally responsible for baby care is taking a sleeping pill, then there has to be another responsible adult in the house who can do the feeding, and not the person who is taking the sedative medication. So in order to take these, if you want to or need to, it's really important to have backup for baby care. It's also very important never to bed share with an infant if you've been taking sedatives, sleeping pills, alcohol, or anything else impairing, because that is a huge risk for lying on the baby accidentally and causing like a respiratory issue. So again, like a lot of the concern with these is not as much about what the baby's getting, but about what they do to mom and how that may affect the baby's safety. Lithium, so this is a really effective and wonderful drug for a lot of people with bipolar disorder. It's a great mood stabilizer. It doesn't have a lot of the nasty side effects that some of the other mood stabilizers have. Unfortunately, it does tend to pass into breast milk at a relatively high rate. So women with bipolar disorder are at high risk for postpartum depression, but also postpartum psychosis. So we're usually watching them very, very carefully. Because of this high risk, like women with bipolar disorder, we usually do want to make sure they're on a really solid mood stabilizer in the postpartum period, which is a period of very high risk. And also the period, obviously, when, if you're going to be breastfeeding a baby, that's what you're going to be doing. So lithium does transfer into the milk at a relatively higher rate than a lot of the other drugs that we mentioned. The range it really varies, but it's estimated to be between 10 and 40% of the maternal weight adjusted dose, but it's like really, really variable depending on the infant size and also on their hydration status, because the lithium is eliminated by the kidneys and you need to have good hydration in order to get it out of your body. Lithium does unfortunately have a pretty low toxic therapeutic window, meaning you don't have to have much more than the dose that you need for the drug to work for it to start causing problems. So for this reason, we monitor blood levels of lithium in all patients who are taking this medication pretty carefully. So lithium toxicity, if you overdose, can include things like cardiac arrhythmias and problems with thyroid and kidney function. And we know that some of these have been reported in nursing infants. So it is possible to get lithium toxicity through breast milk. That said, In most of the cases where this has been seen, the baby has had other risk factors, like they've been very small, they've been premature, they've been dehydrated. So usually there were reasons why this, was not as safe as it would be in a full term, good sized, healthy infant. So I think more and more practitioners are becoming comfortable with lithium and breastfeeding moms. Like, it can be done safely if you have like a full term baby who's good sized and, and milk supply is really good, the baby's well hydrated. It does require close monitoring. You need to check the baby's lithium level, which involves sticking them for blood, which, nobody really wants to do to their newborn without good cause. But I mean, it's something that is possible to offer under the right circumstances. Personally, I think that it is like it's such a lot of work to breastfeed a baby on lithium because you have to have the monitoring. And it can be really disruptive to that time when mom is, trying to, recover from delivery and bond with her baby. And another really important thing to notice, separate from the passage of lithium into breast milk, is that, usually if you're taking lithium, it's because you have bipolar disorder. And one of the real bedrock tenets of control for bipolar disorder is sleep. So moms with bipolar disorder absolutely need good nighttime sleep protection, meaning somebody has to help them feed the baby overnight. Like, no new mom with bipolar disorder should be getting up like every 2 hours all night long to feed the baby, regardless of what the baby is eating, whether it's breast milk or formula or some combination. So honestly, like, the need to protect sleep is actually, to me, a much more compelling reason not to breastfeed than the lithium transfer, which, is potentially manageable under the right set of circumstances. So stimulants, so these are mostly like the amphetamine derivatives that are used for ADHD. We're seeing more and more moms on these medications. So Ritalin is pretty different from the amphetamine-based options like Adderall and Vyvanse. So for amphetamines, Adderall, Vyvanse, the transfer is, in the moderate range, and the toxicity is potentially moderate also. Unfortunately, we don't have a ton of data on these drugs. We only have information from like a few moms. Based on what we know, it kind of looks like the medication stays in the milk for quite a while. So the range of how much the baby is getting has been estimated to be between 4 and 14% of the weight adjusted maternal. The plots on the sides are like drug level in milk for 2 separate moms based on time after the dose. So the 2 different lines are just 2 different metabolites. And as you can see, so I mean, it peaks pretty quickly within like an hour, which isn't atypical, but then it takes like a real long time to go away. Like, you're still seeing like an appreciable amount of amphetamine in the milk at like a day, like 24 hours out. So it's really not something that leaves the milk very quickly. And it's possible that infants who are on the high end can be receiving, drug levels that are serum levels that are actually similar to that of an adult who's taking the drug for ADHD. We don't have a lot of information about adverse effects. So it's a little bit of a black box, but we do know that in general, stimulants are very well known to impair sleep, they impair appetite. They used to be used to prevent, as like diet pills, like in the 50s and 60s, they were being sold as diet pills. And so this obviously is something that you really don't want in your young infant, like your young breastfeeding infant. What they mainly need to do is like sleep, eat, and grow. And so, potentially feeding them something that's going to interfere with that has the possibility for, unfortunate effects. So, I mean, I don't love Adderall for breastfeeding personally for this reason. Ritalin's a little bit of a different story. It has a much lower rate of transfer into the breast milk. And so, for moms who really need their stimulant to function and they want to breastfeed, like, often they can get along with Ritalin for a period of time until they're done breastfeeding. And I mean, personally, I feel this is a more ideal option than Adderall. Sleeping pills, this is kind of a grab bag. Transfer for most of them is pretty low. Toxicity is often low, can be moderate, kind of depending on the drug. I think, again, the most important point here is that the impairment of the mom is more concerning than the transfer of the drug to the baby. Again, because you really need to have an unimpaired adult for overnight baby care. So if mom needs to take a sleeping pill, if it's important that she sleep an uninterrupted chunk to manage her, mood or anxiety disorder, which again is like usually one of the most therapeutic things that you can do, then you definitely need to have another adult available to take care of the baby while mom is impaired. Of the commonly used options, this is Ambien. Actually, Ambien has very, very little like transfer, like pretty much undetectable in most of the cases where it's been looked for. So that's like a reason why I sometimes tend to hand it out if it's something that's needed. It does have this side effect of sleep behavior. So sleepwalking, sleep talking have been reported. Again, you definitely need to have another responsible adult at home, although that's true for any sleeping pill, but even more so for Ambien because of the sleep behaviors. These two, Sonata and Lunesta, they're related to Ambien. They're less likely to cause the sleep behaviors, but the transfer to the baby is a little bit more. So, these are also things that you need to weigh. Trazodone's an older sleeper, also has relatively lower transfer, probably more than Ambien, less than Sonata and Lunesta. Tends to cause a lot of morning grogginess, like trazodone really hangs around for a long time, whereas Ambien gets out of your system quickly, which is kind of another reason why I like it for new moms. Like if they don't have a full night to sleep, but maybe they have 6 hours, trazodone is probably going to still be there after 6 hours, but Ambien really isn't. Antihistamines like Benadryl and Unisom. So these are older drugs, and interestingly, some of the things that have been around for a really long time actually have never been investigated in the way that the newer drugs have been. They don't get the same scrutiny because there's just this kind of accumulation of clinical experience. But these are pretty safe in pregnancy, so we expect them to be safe in lactation as well. Antihistamines can interfere with milk supply potentially, so that's something that you want to be aware of, and a reason why I sometimes would rather go for like an Ambien than a breastfeeding mom versus like a Benadryl or Unisom, which might have the potential to dry her up a little bit. Okay, so alcohol. Alcohol is a very small water-soluble molecule, and it transfers like very quickly, like back and forth between the blood and the milk. You're usually seeing peak levels in milk at about an hour after ingestion. Remember, there's this bidirectional transfer. So, as alcohol is moving from the blood into the milk, it's moving just as fast from the milk back into the blood. So if you have a drink and then you pump, basically all you're doing is get rid of that small amount that's in the breast, and then you're going to re-equilibrate really quickly and bring more alcohol into the milk from where it's waiting in your blood. So pumping and dumping is not going to do you any good. You basically need to wait it out until your liver gets rid of the alcohol. Rule of thumb is 1 drink means 2 hours until you nurse, or until you don't feel impaired anymore, if that seems like a good measure. So effects that have been reported on infants from maternal alcohol ingestion, there's a real grab bag, like, poor sleep, like fussiness, poor growth, and then a couple of really scary ones, like stoppage in bowel function. And there was one report of a cardiorespiratory failure. These were almost all with moms who were drinking like a lot of alcohol, like at least like 5 or more drinks a day, I think, for most of the cases. Having an occasional glass of wine is usually not an issue. If you really want to be careful, it's good to wait it out. Large amounts of alcohol are really not advised for nursing moms. There is this thing where there's this glycan in the malt beer that increases milk production. That's true. It's not true for other forms of alcohol, like anything other than barley or malt beer actually is more likely to decrease milk production than increase it. So wine and hard alcohol do not increase milk production, only beer. And again, like the prescription against bed sharing after consuming alcohol applies just as for sleeping medication. Um, Cannabis, this is also something that we're seeing a lot more. The transfer is kind of moderate. Sorry, transfer is relatively low. The toxicity is potentially moderate. I don't think we have as much information, like there's not as much in terms of reports of effects on infants. This information that I'm going to show you here is relatively recently published. It does seem like if you smoke cannabis will peak in milk at about an hour, which is actually similar for alcohol and amphetamines and many other substances actually. So rule of thumb is you're going to see peak blood levels at approximately an hour after ingestion, which is common across many different drugs. And then it actually is eliminated from the system, slower than alcohol, but faster than amphetamine. By about 4 hours after smoking, we're seeing a lot less. So, I mean, this paper, which I'm going to cite on the next slide, basically estimated that an infant who was exclusively breastfed would get about 2.5% of whatever the maternal dose was. So this is their figure about transfer of the main psychoactive ingredient in marijuana into breast milk. So this is the concentration in the breast milk, and this is time. And again, you can see that there was like a peak at about an hour. And then, by 4 hours, you're looking at mostly gone. So if you want to have a smoke after baby goes to bed, it's a good idea to make sure that baby's going to sleep for at least 4 hours. There doesn't seem to be any information about cannabis that's taken in by other routes. Like, so this is smoked, but it would, would probably be quite different for an edible, and we really just don't have any data on that yet. Caffeine, transfer of caffeine is also moderate, but I mean, it really is not very toxic. I mean, it can be unpleasant to have a lot of it, which I think we may all have experienced. So transfer of caffeine estimates suggest that baby an exclusively breastfeeding infant would receive about 10% of the weight adjusted maternal dose. Again, we've seen like reports of typical types of caffeine effects like irritability, tremulousness, and obviously poor sleep. And this is usually, again, if mom is having like a high maternal dose, like, 5 or more cups of coffee a day. There have been numerous studies of women taking like, more typical amounts of caffeine, like, a few hundred milligrams, which is the equivalent of like, a couple of cups of coffee a day. And most studies do not find any effects on infants at these like more typical maternal doses. Again, separate from lactational transfer, I mean, caffeine often contributes to anxiety, and sometimes we don't even realize how much our caffeine is contributing to our anxiety until we stop it. Anxiety is a really common complaint in postpartum moms, and usually I suggest that if there's a significant amount of caffeine consumption going on, it's really worth taking a week or two to do decaf only and just find out whether that's part of what's going on. And if it is, you can modify your consumption appropriately, and if it's not, then God bless and enjoy your cup of joe. I just want to give a brief overview of some medications that can affect milk production. So hormonal contraceptives obviously are a big one. So the typical hormonal contraceptives are a combination of estrogen and progesterone. And estrogen is basically telling your body that you're going back into reproduction mode, you're ready to have another baby, and that is a signal to shut down lactation because you're going to divert resources from the baby who is, already presumably out there and eating solid food, and take those bodily resources and put them into conceiving and bearing a new baby. So you don't want to take like regular, combination contraceptives when you're breastfeeding. There is a progesterone only, the mini pill, which can be taken safely and shouldn't impair lactation. It's also not quite as effective as the combined. So it's really only really effective for women who are breastfeeding. Stimulants like Adderall and bupropion, which is Wellbutrin, both promote dopamine release, and dopamine is something that works to block the release of prolactin from your hypothalamus. And so those definitely can interfere with breastfeeding. I mean, it's very variable. Like I've had a lot of moms on breastfeed just fine on Wellbutrin, and then some of them really see their milk supply get hit, and it's hard to predict who that's going to be. Aripiprazole or Abilify is something that has like a partial dopamine agonist. So unlike pretty much all of the other drugs in its class, it has the possibility to also reduce milk supply. Most of the other drugs in that class actually, if anything, they increase prolactin and certainly don't impair it. And then again, like I mentioned, anything like Benadryl, antihistamines, and anticholinergics can be drying and may potentially also decrease prolactin. So you can also sometimes see a hit to your milk supply with these, especially if you're taking them early on in that critical period when milk supply is kind of much more vulnerable to disruption. Again, women who have been breastfeeding for a longer time, after like several months, there's really a stabilization, and it's much harder to lose supply by that point versus that early period where it's very vulnerable to perturbation by insufficient milk removal or drugs that impair lactation. So in general, like these are kind of general principles for choosing medications for nursing moms. Anything that's like licensed for use in neonates can usually be like reasonably safe to take for nursing. Obviously, you want to stay away from drugs that have like known serious toxic effects in adults. You want to avoid drugs that are known to impair lactation. In general, you want more drugs that are more quickly eliminated over drugs that are going to be hanging around for longer. And overall, you can minimize exposure of the baby by timing the feed so that you feed the baby right before you take the drug and then have the longest possible time to eliminate it before you feed the baby again. And then these are resources. So, I mean, LacMed, like anybody can go look this up. Like, where did I get all this information? I went and looked it up on LacMed, and you can too. And, if you really want to be serious, you can splash out for Hales, which has much more comprehensive information and also rating scales, which can be helpful for making rapid decisions about. So thank you very much. I hope this was useful, and I'm happy to address any questions.
Thank you so much, Dr. Robakis. I see we have started off with a healthy amount of questions in the Q&A box. I'm going to start with question number 1. If a person waits for the drug to get out of the liver, what about engorged breasts?
So, I mean, you can, pump just for comfort and discard the milk. It's not going to change that much about how fast you eliminate the drug. But I mean, yeah, if you don't want to feed that to your baby, then there's not a lot of other options for it.
Great. Another question. Any suggestions on how to manage a mom with bipolar disorder on lithium and Seroquel for sleep? Adamant about breastfeeding and previously took herself off Abilify before becoming manic. So high concern that she may abruptly stop lithium and choose breastfeeding instead.
I mean, this would be very dependent on the particular case. Like I can't offer specific medical advice for this person because I don't know them. They're not my patient. And it would depend a lot on what the rest of the picture looked like. Like, for example, is this somebody who could be managed entirely on Seroquel, like some people can? Is this somebody who's actively manic, in which case we have a much bigger problem than breastfeeding? And, if she's like needing hospitalization, like the breastfeeding is like a really tertiary concern. If it's somebody who's like currently stable and doing well, and the baby's healthy, and the mom is, able to, manage the requirements for monitoring, maybe she wants to breastfeed on lithium. I mean, again, like it can be done. You have to be willing to, have the baby's levels monitored. So there's many possibilities, and without, I don't think there's like a one size fits all answer to that.
Great, thank you. We got so many questions that I just bumped one that I know many people were interested in hearing about. Okay. What is your experience on milk supply with hydroxyzine as an anxiolytic or sleep agent in a breastfeeding woman?
I mean, honestly, I don't use it that much. I don't find it that useful for sleep. Sometimes it's more useful as an anxiolytic, but because, I mean, honestly, because there's not a lot of data for it in pregnancy, I tend not to use it in pregnancy. And so if they've gotten through their pregnancy, usually I've had them on something else, and I'm usually not starting hydroxyzine in the postpartum. So honestly, I mean, based on the properties of the drug, I would expect that it could potentially dent your milk supply. But because I just don't use it that much, I don't have a good sense of like, how common that really is.
Great. Any thoughts on potential long-term psychological effects of SSRIs on infants?
So in the very, very long term, like adulthood, there have been, okay. So it's important to make a distinction between exposure in pregnancy and exposure in breastfeeding, because most of the information that we have has to do with exposure in pregnancy, because that's usually more like the baby's getting much more exposure transplacentally than they're getting, through the breast milk. Like, the lowest of the SSRIs are giving the fetus like 20 to 30% of what the mom gets. And in lactation, the baby's getting just a few percent of what the mom gets. And also the plasticity there's much more like development going on. I mean, obviously there's a ton at both times, but the really, basic development is happening antepartum. So I really would not see any reason to expect that you would see like long-term psychological effects of SSRIs on a nursing infant. I can't cite you specific data, but again, it's because the likelihood is like really low given the dose and the timing. Long-term, there have been many long-term neurobehavioral investigations of SSRI use in infants exposed antenatally, so during pregnancy. Most of them find nothing, like 90% of them are like turning up zero. There have been a couple of very long-term studies now that came out in the last couple of years that looked at like psychiatric disorders in adults who had been exposed, antenatally. And the thing is, I mean, one of them did find like increased rates of depression, but it's very hard to say because, I mean, this whole literature is like super confounded by the fact that women who take antidepressants in pregnancy are generally more psychiatrically ill than women who don't take them. And it's really almost impossible to kind of tease that out. And I don't think that any of those studies really did a good job with that. So overall, this is not something that I'm worried about. I'm definitely not worried about it for breastfeeding. I don't even really think it's a problem for pregnancy, but I think like it's something that is going to need to, we're going to need to continue to study. But the bottom line is that we actually know a lot more about the adverse effects of the mom being actively mentally ill during the pregnancy. And those are like super pervasive. They have a clear neurodevelopmental impairment in infants, toddlers, preschoolers on up, from mom being like actively depressed or anxious, or, having, an active mood episode for bipolar disorder in pregnancy. So we know a ton more about that. It's way worse. And overall, if you're looking at the developmental effects on the baby, in general, it seems like you're much better off with the medication than with the untreated mental illness.
Great, thank you. Dr. Robakis, do you know of any hormonal birth control that alleviate PMAD symptoms?
So there have been like a couple of studies that looked at estrogen as like a treatment for PMADs. They're small. They were a long time ago. There's not ongoing interest. I mean, estrogen is going to, really impair lactation. So it's not even an option for, for women who are wanting to breastfeed. So it's usually not something that we're using. We're usually leaning more on antidepressants than on gonadotropins.
Are cannabis properties stored in body fat?
Yes. Cannabis is highly lipid soluble. It gets stored in like all of the fat cells in your body. And actually, good point. I should have said this during the slide. So that slide that showed the cannabis, that was in moms who had like abstained for several weeks and then had like one hit of like 0.1 grams. If you're smoking routinely, then that is going to be stored in, all of the fat in your body and like slowly released over time. So you're going to, start to have like a more chronic level of cannabis in your system. And that has the potential for, again, being like creating like a low chronic level of milk. I totally should have said this. So thank you for that question. So, routine, regular daily use of cannabis is actually kind of a whole different animal than like, toking up once in a while.
Great. Another question, what does adjusted maternal mean?
Oh, so weight adjusted maternal, so adjusted for the weight of the mom. So, I mean, if the mom weighs like 55 kilos and she has like a certain mgs per kilo of drug, then you're adjusting for the weight of the baby. So they calculate it by the amount that's in the milk, like divided by the body weight of the baby.
Great. Can you say more about COCs? I was under the impression that after 6 weeks, a significant drop in supply was a risk, but relatively rare. Would you agree with that?
I mean, I agree that supply stabilizes after, after 6 weeks. I think it's very individual as to whether, it would be reasonable to start a COC after that. I mean, I see that there's somebody in the comments who mentioned that she notices the mini pill does adversely affect milk supply. I mean, I think I've seen this as well, but I mean, sometimes it's definitely not anywhere near what you would see with a COC, and, people need birth control. So yeah, I mean, everybody's very different. Like a lot is about your individual physiology.
Okay. Is most of the information that you've shared tonight similar to how you would recommend for pregnancy as well?
Not necessarily. Like I mean, as I mentioned, like like the Adderall is something that I actually feel that's unusual, but I would almost feel more comfortable with that in pregnancy than breastfeeding. It doesn't really seem to be associated with congenital malformations, and then the growth issue. I mean, the baby's going to get what they need from the mom, whereas like once they're out, then they need to eat on their own, and that's where I mean I might be more concerned about feeding baby a stimulant. So I mean, no, I think, and also like again, like the Ambien, like that's something that is, I feel more comfortable with that in breastfeeding because it doesn't transfer like hardly at all into breast milk, but it's not really like that well studied for pregnancy, and I don't love it at that time just because there's kind of a paucity of data. So no, I would say that it depending on the individual drug, recommendations for pregnancy and breastfeeding could be rather different.
Okay. What's your opinion on breastfeeding mothers who are on Prozasin for PTSD? Any harm to the infant?
Off the top of my head, I don't remember what the transfer is like, but I think it's pretty low. I don't remember it being particularly high. So, I mean, I honestly, I'd go LactMed that if I had to give somebody Prazosin, but my recollection is that it's not a lot of transfer.
Okay. You kind of answered this, but it's a question that keeps coming up again. So I'm going to ask it slightly differently. What are the negative effects seen in children from untreated anxiety, depressed pregnant moms? Curious so I can have the info when trying to educate my patients.
So, I mean, it differs like a little bit based on like what the actual, what the diagnosis is. For sure, we see reductions in the term of gestation, reductions in birth weight with anxiety, increases in risk for like difficulties with the delivery, like increases in risk for instrumental delivery or C-section. In moms with anxiety, it's pretty clear that infants have this like lower startle threshold. So you can see like behavioral effects of anxiety in neonates. And interestingly, this is actually reversed by treatment of mom with SSRIs antenatally. That's been shown in a few papers now. In the long term, more so with anxiety, you can see increases in internalizing and externalizing behaviors out to preschool. As you get farther out, it starts to get more confounded because you're looking more at effects of mom's ongoing, mental health issues. Like, the older the child gets, the more you're starting to see that the adverse effects are related to like extended periods of maternal, depression and anxiety throughout childhood. And that starts to take over from, anything that you would see from antenatal exposure.
Is there any special consideration for increased transfer of combination of SSRI and Wellbutrin as an augmenter in breastfeeding?
I mean, in general, like it depends on the specific drugs, but often you'll have two drugs that are using like the same liver system to eliminate them, and then you'll get buildup of both of them because you're basically just clogging up the elimination machinery. So again, like I mentioned, like in the few cases where seizures were reported on bupropion, it was usually mom taking like a combination of drugs that might theoretically have impaired the elimination of the bupropion and allowed it to build up to a higher level.
Question from Elliston Pediatrics. We're finding so many parents with postpartum anxiety. All of these moms have not been identified as having a mood disorder prior to pregnancy. Since we are in pediatrics, we don't know them before. What is your go-to medication for moms with debilitating anxiety postpartum?
I mean, an SSRI is it's hard to go wrong with. I mean, their downside is that they take a while to kick in. But honestly, I mean, with perinatal women, I actually think they kick in faster than with a lot of other populations. I mean, Zoloft is great. It has, you know, it's very calming. Many women with anxiety find it very helpful. The only thing is like, this is a little picky, but you never want to give an unopposed antidepressant to somebody who has bipolar disorder. Like you don't want to hand somebody Zoloft if they have bipolar disorder. So, I mean, if you don't know the mom and you don't know her psychiatric history, I mean, ideally it's better to hand her to somebody who does have that information or can get it. But I mean, if you're sure that it's not somebody with bipolar disorder, then I mean, Zoloft is usually, safe, well tolerated, and really good for anxiety and depression both.
Great. I think we're going to take two more questions. Is there an evidence-based framework to support shared decision-making around meds between physicians and patients?
I don't know, but I think shared decision-making is always a good idea. But I can't cite you a paper that looked at it, but I mean, I would say in general, I support that.
Okay. Have you seen any studies done on the correlation between smoking during pregnancy and the effects on breastfeeding during the 80s?
I'm not sure what this is getting at. I don't know that I'm specifically familiar with that. Smoking is generally like really bad across the board.
Great. Well, I think that is all of our questions for this evening. I want to thank you again, Dr. Robakis, so much for such an informative presentation tonight. And I just want to let everybody know that we will be sending around a recording of this evening if you got here late or if you had to leave a little bit early. And I just also wanted to encourage all of you. I know we've got so many providers here that are currently treating new and expecting mothers, whether it's lactation consultants or therapists or pediatricians or OBGYNs. I just want to thank everyone for joining and let you know, although we are located in New York City, I see so many people joined us from all over the world, including Hong Kong, which is really exciting, that we are here to, if we can't actually provide outpatient treatment or day program treatment to women, which we do in the tri-state area and in some other states across the US, since there's been a lot of relaxing of licensing laws throughout the pandemic. If you do call us and you're interested in finding treatment for a patient, we'll do absolutely everything we can to put you in contact with perinatal specialists. If you need to reach out, you can call us at our very simple number 212-335-0034, or you can visit us on the website at www.themotherhoodcenter.com. Thank you again, Dr. Robakis. Thank you everyone for joining us. And hopefully you'll be back here with us in 2 weeks for our next monthly provider seminar. Everybody have a great night.
Thanks so much, everyone.